So, first of all, I want to start by thanking everybody for putting this together. It was what a beautiful and wonderful presentation, Bridget, and really helpful. I of course was the new case study definitions is very interesting, and I think that'll help us better research and better understand lipedema. I also, well, we'll talk more with questions, but I actually think there's only 3 stages because there's lymphatic involvement in all 3 stages. So, all right, let's see if this works. I guess no. I'm just gonna, so again, this is Lipedema month, Lipedema Awareness Month, and so this is the month where we really want to share our awareness and try and encourage others who don't know about this to learn about it. So I'm going to go over the key points from on lipedema surgery outcomes, and so this was published last November, and I've just been told by the plastic and reconstructive PRS that this was the top. This was awarded the top paper for the plastic and reconstructive surgery global open for the year for last year. And so, we looked at outcomes. So what benefits can lipedema reduction surgery have for the patients? This is the original article and its abstract. I don't expect you guys to read that. This paper did a lot of firsts. It was the first to look at the lipedema reduction surgery in the United States, and it was first to document gait improvement, joint alignment improvement from lipedema reduction. It was first to correlate patient-reported outcomes with objective physical measurements. It was the first to show improvements in mobility, which correlate with future disability and life expectancy. So that's really powerful to be able to, show that. And it was the first to use the same outcome measurements used in orthopedic literature in this treatment of lipedema for mobility, quality of life, and knee flexion. And it actually showed better improvements in, for example, knee flexion and knee alignment than are achieved with a total knee replacement. So let's get down into how do we measure these things. So these are, this is a lipedema leg, of course, and over here on the far right is that's a lipedema patient and me measuring with a goniometer the alignment of the knee. So a normal knee would be straight, and that would be a completely the top and bottom arms of the goniometer would be straight. You can see there's a curve there. That is a valgus curve or valgus deformity of the knee. This is very common in lipedema women. I'd say 80 or 90% have this misalignment, and it's caused by the bulk of the lipedema tissue. It's just it is a mechanical derangement of the normal orthopedic alignment. And then the next one over, the middle one, is measuring knee flexion. And so again, with the goniometer, just how far someone can bend their knee. This is followed extensively in orthopedic literature And so I brought this from orthopedic literature to study it in my lipedema ladies. So this is now getting into the details, and you can see here, going from left to right, that the degree, so starting with the left knee, there was about 120 degrees was before surgery, was their knee flexion. Now that's a normal knee flexion is 135 degrees. So that's all. So the average lady with lipedema has a restriction caused by the bulk of their lipedema tissue to their knee flexion. And then with surgery, that improves just under 10 degrees of improvement in the knee flexion. That's the same thing seen in the right leg. And then the next two slides show the angulation or alignment of the joint. And that improved by, started quite angulated and improved by about 3 degrees. And the final two are gait. And so, as you can see in the bottom, before surgery, 80% had an abnormal gait, and after surgery, 80% had a normal gait. So that's going to improve. That also goes along with mobility and other things. Puts less. So these decreasing things on the stresses on the joints helps them walk more normally. So this is this is just looking at knee flexion. How much knee flexion do you need to do certain activities? And so cycling, you only need 90%, but with stair descent, you need at least 100 to 105 degrees to safely go down stairs, and you need 120 degrees to run, and to get in and out of the car, you need the full 135. We're also getting in and out of the bathtub, you need the whole 135 degrees. So in our study, we found that 16% of our patients who underwent the surgery had a improvement in their ability to go up and down stairs. So we used, so I'm going to get more into that. So we used, these were part of a composite mobility score that we looked at. Now this is the PROMIS mobility score, and PROMIS is a tool developed by the NIH for research into all sorts of medical conditions. It's highly validated. So it allowed us to expand and see these improvements and what they mean in real life to our patients. So 16% improved their ability to walk at a normal speed. Now this improvement is actually associated with improved life expectancy and decreased ability to, or decreased incidence of disability. So that's a tongue twister, but I think you guys understand what I'm saying. So there was a 27% saw an improved ability to run a short distance, and this is also improved. This is also correlated with life expectancy and decreased risk of future disability. And 12% of this patient's ability to stand or not showed improvement. Now, this getting a little more into the study protocol. These were all patients who had already started the conservative therapy mentioned by Bridget. You know, they were wearing medical grade compression. They were following an anti-inflammatory diet, and I just since she brought it up there, I feel like that's important because we know that refined carbs, highly processed food is inflammatory and does worsen the symptoms and progression of lipedema. The vast majority of them also went advised to maintain or lose weight depending on where you were on that spectrum. And now looking the year before I published a paper looking at just these conservative measures. And they were shown to slightly decrease the limb circumference and reduce the pain. But these conservative measures did not show the mobility. We did look for the mobility improvements or the improvements in knee mechanics that we saw with the surgery. Also, there was a 12% decrease in overall body pain between before and after surgery. So we also looked at this RAND SF36 is the most widely used quality of life assessment. So it goes over all sorts of things that are instrumental for our lives. Our overall health, our limitations of health, our psychological health, etc. That would be, in there, that would be under emotional well-being, social functioning, and pain control, etc. Global health is also measured. And there was a 12% improvement in global health. And so I'm very proud of that. Very proud that there was 11% in ability to increase activities of daily living, such as eating or transferring or toileting or bathing, etc. So 13% improvement in ability to complete tasks due to pain, and a 10% ability to complete tasks by emotional problems. So also we looked at lobules, and so lipedema has lobules, which the arms, legs, etc. It's one of the characteristic developments of it, and we saw that percent of patients with lobules decreased dramatically from almost 100% had lobules to just a few percent had lobules after surgery, and that would be breaking them down into lateral lobules and knee lobules or lobules on the arms. They all improved significantly. So so the before is actually at the bottom, and the upper is after. That's a lipedema surgery. And this is also from the paper. You can see the arm lobules and the lateral thigh lobule improves, and then this is that knee lobule before and after. So it could be argued that because lobules are really one of the key characteristics used to categorize between stage 3 and stage 2, that the removal of the lobules may actually lead to a regression from a stage 3 to a stage 2. Well, that has. Thank you for your attention. I really appreciate that. That's kind of that. I want to leave some time for questions and answers, and also if you have questions, for Bridget, we'd love to entertain them.
What prevents, after you do your surgery, what prevents that from coming back? I mean, is there a guarantee that that's not, they still have to follow diet, exercise, but how does it prevent from coming back?
Yeah. Do I need to repeat that? Yeah. So what prevents the lipedema from coming back after it's been removed? Well, first of all, there is no cure for lipedema. And surgery is, while it has great benefits, it certainly does not cure. It has to be, the benefits, lipedema has to be maintained with the lifestyle changes, with the diet, with compression, those need to be maintained for lifelong. Now, in the United States, we do have more recurrence, and I previously published a paper that also showed that there was that recurrence rates were higher in the U.S. compared to Germany. That part of that is we have a poor diet. I've been to Germany many times, and there's no fast food in Germany. There's a few restaurants in the big cities, but I mean, in the United States, we have a lot of, there's fast food, our diet is poor. We don't walk as much as they do in Europe. And we get, I think that's, so adherence to those things really can backstep or cause recurrence or regrowth of the likely tissue.
So with that being the case, is there a limit to how many times they can have surgery?
Well, is there a limit to how many times you can surgery? There's no technical limit, there's no finite number. And it all depends on how many, so it also depends on how much is removed each surgery. So there's some surgeons who remove only a few liters, don't get quite, and they're going to require more surgeries and perhaps, but it's not, the answer is, of course, that there's no limit and you could continue, but to really I think for our patients, we want them to just have it as one surgery in each area, and that's my goal, and that's what I do for my patients. I very seldom have patients come back, and I've been doing this for close to 20 years, and I very rarely have patients come back for additional surgery after in an area that I've already treated, but I can't speak for all surgeons, and honestly, very few surgeons have kind of the experience and the long-term track record that I have, and I also think less experienced doctors less experienced surgeons don't quite, you work things out. I mean, I'm a better surgeon, in the last 5 or 10 years than I was 20 years ago. I mean, I'm more effective. I have a better team. I mean, this is just, how the practice of medicine, you get better and better the more you practice.
I find it fascinating that the knee replacement, you've had good results without someone going through the knee replacement because of the removal of, do they get screened first with a ortho, or how does that work?
So that's a great question. So first of all, lipedema causes knee pain. So first of all, she wanted to know, how, looking at the knee replacements and our improvements, and how does that mesh with the treatment of knee pain by orthopedics? So both lipedema and arthritis in the knee can cause knee pain. So and they can both, they're not exclusive. They can be both. We do see improvement. I mean, obviously, if they have a very advanced arthritis in the knee replacement is what they need and is going to be the most effective thing for them. If they have, if their knee is if the knee joint is in better shape and they have knee pain, it often is caused by the lipedema and will improve with the lipedema. But in addition to treating the lipedema, also improves the mechanics on the knee joint. Now, it doesn't repair a knee joint. I want to be clear where the limits of this is, but it does improve mechanics and gait mobility, and that allows the patient to last longer on the needs that they have.
I think we had a couple more.
I'm not familiar with your practice at all, I'm from down south, but can you tell me what techniques you use and like how big incisions are, things like that with your surgeries?
So, yeah, so I don't actually make incisions. I make these little adits. They're 2 to 3 millimeters is the size of the openings, and they're just made with a biopsy punch. So if you saw when Bridget did the standard case thing, one of the doctors is Dr. Wright. She's really kind of a pioneer of lipedema reduction surgery. And by the way, I just want you to know, I say lipedema reduction surgery versus liposuction because liposuction is a cosmetic operation and it's not geared towards improvement of function. Lipedema reduction surgery is a functional surgery, and the goal is to improve the mobility and life functions of the patient. So, but some people call it liposuction. I'm fine with that, but I prefer lipedema reduction surgery. But Dr. Rackridge kind of pioneered this what we call the limb sparing, so basically longitudinal cannula strokes and to avoid crisscrossing or transecting lymphatic vessels. Now, what this came out of, so originally, this is, actually close to 30 years ago, there was a big outcry because in the lymphedema community, they were like, they were yelling at us surgeons, you are killers of lymphatics. This was
That's what we're talking about.
So, and so there was a lot of studies done, anatomic studies and other studies that showed that this technique does not interrupt the major lymphatic collecting ducts. And so that's the type of technique that I use. I'm part of the traditional old guard of surgeons that have been doing this for a long time. Now there are new surgeons, new specialties like plastic and reconstructive, and they don't believe there needs to be any of these precautions taken. So I have actually reported on, and I feel it's devastating for women who have lipedema that suffer worsening of their lymphatics from the surgery, and it can occur. Now I don't know, so I would personally, like this like everything goes to my heart, and I wouldn't be able to sleep if I knew that. So I'm going to take every precaution. Now, there's others who feel that that's not necessary, and it would be honestly impossible. It'd be unethical to study this. Of course, we would never want to intentionally harm someone's lymphatic function. But that's the type that I use and believe. And honestly, that's the one that almost all the literature till less than like 5 years ago showing the benefits was really done with this kind of technique.
So just to clarify, are you saying you use a different approach, like you're going more vertically, or you use a smaller cannula, or what?
So I do use smaller cannulas. So she wants more specifics on the type, on the surgical technique. And I do, and so specifically, I do use smaller cannulas. Obviously, I use blunt cannulas. I think everybody should. I don't know if there's anybody who's not, but I use generous tumescent. Not everybody uses even tumescent anesthesia, or if they use just a wetting solution, they don't let it wet and gel in the patient for a half hour to an hour or two, which helps in the extraction. The other thing is, so I use the smaller cannulas, I use the longitude, so I go parallel to the lymphatic collecting. So the major lymphatic collectings, they run along the fascia, the ventral medial ones are some of the most prominent. They're close to the saphenous, saphenous sheath, running along the muscular fascia, and those are the ones that I most specifically try to avoid injury. Okay, thank you. Yeah, no, that's a great question. Thank you very much for that, and I appreciate that.
Sorry. I was thinking about, did you, and maybe I misheard, did you say that you felt that there was always a lymphedema component with lipedema? And if so, how does that differ? Because the Europeans feel a little bit differently, right, about lipedema?
So here's something, and so we see non-pigment edema in all our lipedema patients. So, and I mean, that to me is part of the definition and should be part of the case definition. I'm going to check, but I'm going to respond to that if it's not. Now it's really mostly the Germans. Everybody else is kind of, less strident about this, but the Germans feel that you don't, that the compression and the swelling we see our reports of our patients having is not real swelling, and the compression is just working as an anti-inflammatory effect. Now, I think they're all wet. I think they're like off the mark on that. But there is a controversy about that, and it will be settled. I'm actually going to be part of the international. So the 19th, we're going to release the Lipedema World Alliance, and I'm an author on this, the international consensus, and then we're going to update again the consensus in Graz, Austria this September, and I'll be a member of that committee as well. So I'm going to definitely try and straighten some people out. I'm just kidding. Of course, the answer, I mean, it's the arguments the Germans make are reasonable, but I just don't feel I feel like they go against the evidence that we have. We have evidence from bioimpedance that there's increased tissue edema in our lipedema patients. Even stage 1, I'll go into where it is. It's not in every stage 1. It's not in every stage 2, but the higher in stage, the greater percentage have evidence of increased interstitial edema and increased edema in the limbs affected by lipedema. So, as I said, where we can clearly point, Dr. Crescenzi in Nashville has clearly shown there's increased tissue sodium in lipedema-affected limbs. Well, what sodium is an ion that basically, if you attracts and holds on to water. If you have increased sodium ions, they go right along with increased water. Now they're bound up in proteoglycans, like gel-like substances in the limbs. And so you're not going to see free water like you sometimes can see with lymphedema. So there is a lymphatic component that only occurs when, as Dr. Roxon has clearly shown, you only can have increased edema in tissue when there is some impairment of lymphatics. But it's a different impairment than where there's lymphedema, where there's obstruction to flow or lack of congenitally lack of lymphatic vessels that impairs the complete the drainage of the affected area. But it still is, if we understand as the new, as our new understanding of swelling and edema has come forward in the last decade, that we know that there has to be some lymphatic impairment. And so we see it, we can see clear evidence of it in some stage 1, in the majority, 70 or 80% of stage 2, and even higher, like 95% of people with stage 3. Now, that's why I think there's only 3 stages of lipedema, because one is stage 4, this lipolymphedema, which is really already present in all the other stages. So it doesn't add meaning. It's a stage without any meaning. So an unnecessary stage. That's where we are here. Now, again, there's debate, and that's healthy. And I think, when these sort of debates that I'm discussing are really what help us better understand, because that really requires more rethinking and re-looking at this. That's what. But I welcome that. But, so thank you for that question. Come on up, Richard. I'm sorry.
You're doing such a great job.
So I have a question for you. So I really appreciate. Well, I mean, so this is on her talk, so when you were talking about the standard case, so they're now saying, and I agree with this, that there does not have to be an ankle or wrist cuff to diagnose lipedema. And what are your thoughts on this?
So I'll wear my CLT hat, and I would say that whatever the highest correlation or percentage of women who do have most of the symptoms of lipedema, whatever data we have to show. So if you have a woman who clearly has lipedema but maybe doesn't have the cuff, well, maybe that's just one of the diagnostic criteria that she is missing or doesn't experience. Physiologically, I don't think that should negate the underlying disease process or any other symptoms that she's feeling. So that would be my honest
So I want to just, and I want to talk to you about, can I just, because I've really done this wonderful in this standard case definition, and I do, if you would just, as a spokesperson for the Missouri LE&RN chapter and the research, how important do you think that is for future studies to have a clear definition?
For the framework?
Yeah.
I think it's hugely important. Yes. I think that if you have a universally accepted standard to work from, then just think of all the open doors you would have in being able to compare study to study. Having been president of the FDRS, one of the challenges I can see listening to brilliant researchers and doctors from across the world is that maybe a big piece is missing is the standard, because it makes it difficult to compare one person's practices and outcomes to another.
Right. Yeah, that's so important. And also, so that we know when we're researching lipedema, that we're researching the same thing. Because if we're not stringent on our diagnostic criteria, and this is, our research will not have the meaning that we need it to have. And so, I think that's critical. And I really, the Lipedema Project and LE&RN collaboration on this is so helpful and so important.
Well, and the social or the patient aspect of that, like all the women at that conference were like, it took me 10 years to get a diagnosis 14,000 people, they were all searching for so long, and if there was like I check all these boxes, buddy, like, look here.
Yeah, exactly. Yeah, so that's really a great point. The average woman with lipedema goes 10 years of presenting to healthcare providers with their symptoms before they get diagnosed.
And to be told all kinds of awful things that psychologically these women have suffered for all those years.
Right, right. It's really unfortunate that, that happens, and yeah.
Do you think if there was a standard of care that insurance would start to have to cover a diagnosis?
So let me explain. No, and so we already did publish the U.S. standard of care, and it does have the criteria, though they're not. It's not what all the ones that are discussed in this standard case agreement have been previously discussed in our standard of care, but this will give you a point system that will allow, so that we're consistently, even because previously we have the criteria that may be present, but this will be a definitive number of the criteria, what are essential, what does not have to be there, and we're still talking about the same thing, and that is going to be very helpful. And I think but where it goes to insurance coverage, they basically, I mean, the truth is they pay for what they want to pay for. They are largely do not care what the medical consensus is or what your personal doctor says. They cover there's in small, fine detail is in a summary plan benefit, and they look for any way they can exclude or not cover the treatment for their lipedema insured. For them, they need to maintain their healthy profits, and they will that is their primary objective. Whether their insured people get the care they need is less important to them.
And just to clarify, you as standard of care that you're referencing it is a paper that you co-authored,
Right.
correct? So different from the framework that was presented tonight in the video. Where could people access that article?
Well, it's available online. I did not bring copies. We have it on my website as well. But it's open access. So if you there's a link on my website, and if you go to that, there's a link to get the full paper. But you can also download. As an author, I'm allowed to let people download the PDF as well.
You want to reference the website?
Oh, lipedema.net. Sorry, that's my website. Okay. So,
Are there any other questions?
Is there a question?
Okay.
Is there a difference between the fat cells that we generate from being obese versus the fat cells that somebody generates from lipedema?
That's a great question. So, yes, there is. Okay. Well, so the question is, are the fat cells? The question is, are the fat cells different in lipedema versus from obesity or other fat cells? And there is some evidence that the lipedema fat cells function biologically different. And what that means is, if you take lipedema fat and you take it out and you study its replication, and it's going to replicate or expand more readily than normal fat. are some, they both, obesity and lipedema have increased inflammatory markers in it, but they're actually slightly different inflammatory markers, and the lipedema fat appears to behave metabolically different than obesity adipose tissue. So really good questions, thank you. All right,
One more. Where, and this is right next, I think the answer, where do we get your compression garments? And it's so hard for us in our busy clinics to figure out where and how and what exactly we want, it's just hard.
No, and that, thank you, and so lipedema ladies are hard, they don't fit well in compression, but we find that there are brands that are more comfortable and fit better for them. The two, we stock Sigvaris pantyhose, and I feel that they work good, but there's also other products that work very well. We also really like, there's a couple of European weaved products. One is called Solida, and one is called Cizalzis. Now, I'm very passionate, so I believe women with lipedema have to wear at least part of the foot has to be in there. A lot of women who just try and wear the knee highs and capris, they get it binds in and it goes in their calf level, and that becomes painful. So I really think the best are actually the pantyhose. And they don't, they 20 to 30 is adequate, and they really have to just fit really well on the, they don't have to be super tight on the upper body, they just really have to, the calf is really the most important part.
All right, well, Dr. Wright, I want to thank you for being here, and thank you for your passion and your care for patients and for presenting such wonderful information to everyone tonight.
Thank you so much.